data that we are seeing underestimates heart failure, and the reason it's underestimated is because we do not diagnose heart failure with preserved ejection fraction as carefully in the community setting as we need to. So as impressive as these numbers are, I can guarantee you that this is an underestimation. So with that said, why don't we hear from a patient what is it like to live with heart failure with preserved ejection fraction?
I think I was a very active person. I worked full-time. I took care of my home, my husband, my son. I used to work in my gardens a lot. My gardens used to be a lot nicer, but I can't do that anymore. For several years, they diagnosed me with reactive airway disease and asthma. And so I was doing the breathing treatments, but I just didn't get better. And I do have reactive airway disease, but it's a minor part of what's wrong. The real driver in my breathing problems was the heart failure. What I noticed was that I was always stopping to catch my breath. The breathing treatments didn't seem to do the job. And it was just very frustrating. So all the while, of course, my heart failure was getting worse. But it wasn't being attended to because if you x-rayed my chest, my heart was a good size. There's more to heart failure than size. And that's what I think physicians need to think about. The fact that her heart is a normal size does not mean her heart is normal. There are other things we need to think about. I was misdiagnosed for a long time, and finally a pulmonologist I was seeing said, you know, you just don't act like a person with this condition that we say you have. I have a cardiologist I want you to talk to. And I said, okay. So this young cardiologist came into the room and he talked with me and he examined me and he said, I think you have heart failure with preserved ejection fraction, which kind of meant nothing to me at the time. And he said, but I need to do a catheter exam to be sure. So the next thing you know, I'm in the cardiology cath lab having my heart catheterized. And that confirmed the diagnosis that indeed I do have heart failure with preserved ejection fraction. As he was telling me about that, he said, your heart is small, it's hardening, and the blood can't get into it. Once it gets into it, it gets out just fine. But you can't get it in, it backs up in your lungs, and that's why you were misdiagnosed with lung problems for so long. And my response, which was so incredibly intelligent, was, I can't have a hard heart. I'm the softest hearted person I know. And he just rolled his eyes. I was being attended to. I mean, the physicians were listening to me and they weren't. They were hearing me talk about trouble breathing, about being worn out, but they were putting it to a different problem. And they weren't taking that step of going further and considering whether or not I was having trouble with my heart. The biggest symptoms are tremendous fatigue, difficulty breathing. Our blood pressure just kind of goes all over the place. Sometimes it's high, sometimes it's low. But the fatigue, and people say, oh, well, you're just tired. No, fatigue is different from tiredness. Tiredness is what happens when you have been busy and used up your energy stores. Fatigue is not having any energy stores. Fatigue is getting out of bed in the morning is work. Getting dressed is hard labor. So think about fatigue very differently than you think about tiredness. I was really lucky. I had a really bright, caring pulmonologist who thought beyond what he knew to understand there might be something he didn't know. And so he called in a cardiologist. And luckily he called in a cardiologist who cares about HFpEF. I really want, when women go into a doctor's office with nebulous symptoms, I want the doctor to think first of all about heart failure with preserved ejection fraction and either rule it out or go into it, but get it on the table and deal with it. Don't ignore it, don't pretend it doesn't exist, because women are dying. And I'm living, and I'm lucky, the things I used to do. I can't garden ferociously like I used to, but I can still enjoy my gardens. I can still enjoy other people. I can still do volunteer work. So I think with heart failure, the issue has been finding ways to still feel that I have a meaningful life, and to find joy in my life.
What is very interesting is that not only is, unfortunately, the prevalence of heart failure very common, this history is very common for our patients as well. So Martha, what do you think about this whole thing about, this is just fatigue, it's lung problem, and that heart failure is not in the differential diagnosis?
So we see this all the time. This is such a common story where for years patients have sometimes had the symptoms, but people have misdiagnosed them. And it's actually, her story, I just started thinking about how many patients of mine had very similar presentations. I think that sometimes discounting shortness of breath immediately as a pulmonary problem seems to be happening more often than not. And I think that we need to be teaching more about HFpEF as a diagnosis, and people also putting the heart first, like thinking about cardiac conditions. Of course, HFpEF is one of them, but I think that's often the problem, especially when it's with a woman.
Yeah. And then Kavita, this whole issue that, your EF is normal, your heart size is normal, so it cannot be heart failure.
Yeah, I would agree with Martha. I mean, this is such a common, again, presentation, and what a remarkable, testament and just relaying of a journey from diagnosis to now hopefully treatment with you, Javed. But women in particular coming in with non-specific symptoms, the distinguishing between fatigue and tiredness, I feel like is now stuck in my mind, and I'm like,
yes.
That was just such a light bulb moment to use that with patients when really trying to tease out the difference. What adds to the complexity is the comorbidities that these patients have, like obesity and cardiometabolic syndrome, CKM syndrome, often presenting with similar symptoms that overlap. How do you tease out those symptoms versus heart failure? But it comes down to disease awareness and education, and hopefully we start that here and through this meeting.
Yeah, I mean, the number one place where heart failure is diagnosed is unfortunately in the emergency room, and if you look back at the medical record, there has been mention of heart failure symptoms for almost a year, but it just keeps getting delayed.
All right, well, when we're thinking about the prevention of heart failure, because as a preventive cardiologist, that's what I think about. I know that my colleagues here treat advanced heart failure, but I feel like we need to be changing the paradigm to be thinking about how can we identify people at risk sooner and make it so that one day they won't have symptoms, that we're able to identify who's going to get heart failure and what we can do ahead of time to prevent the consequences of. And I think it's going to take partnerships amongst a lot of the healthcare system. So of course it starts with the patient in the center, but primary care needs to be at the table. We need them because they're the ones who see the patients first. And with primary care, of course, our nurses, our nurse practitioners, our physician assistants. But there's other people that see patients at risk for heart failure. And that includes our endocrinologists, our nephrologists, all the people that take care of people with cardio-kidney metabolic disease, because the cardio-kidney metabolic pathway is usually more often to heart failure. And I know at this meeting we've been talking a lot about this cardio-kidney metabolic problem that we are seeing in so many of our patients. We also, though, working with genetic counselors, working with pharmacists, working with registered dietitians and with physical medicine and our cardiac rehab programs, every part of this needs to be part of the system to really work at identifying patients at risk and potentially having the power to prevent heart failure, progression, or even the diagnosis thereof. I think the benefits, of course, is that if we start spreading the word and teaching everyone that clinicians at all those different levels will develop familiarity with our guidelines. They'll be able to identify patients at risk, and not to say that they have to manage them. They might just know that this patient needs to be referred on so that they can get the treatment they need. And I think that, you know, we're hearing a lot at the American Heart Association about the cardio-kidney metabolic work groups, which even have navigators that are taking patients to the right places, sort of a little bit like we've done in the past with like our TAVR patients. I think starting to think about that for all these different risks that seem to cluster together, how can we identify them early and how can we get them on the right treatment pathway earlier? I think that this will result in quicker referrals, fewer delays in care, and also improved interprofessional trust if we're all working together.
Okay, so we're going to segue to a case study. Some of the features of this case will seem familiar from the video you just heard, but this is actually a case that's different from the patient whom you just heard from. So this is a 64-year-old woman referred to our HFpEF clinic at Hopkins. She presents with 2 years of progressive dyspnea with exertion, with walking in particular, two-pillow orthopnea, bendopnea, which is a symptom of shortness of breath with bending over, which is actually quite sensitive and specific to heart failure, and occasional episodes of paroxysmal nocturnal dyspnea or nighttime awakening with shortness of breath. Her comorbidities are very typical for the patients we see in our clinic: hypertension for years, obesity, sleep apnea, and she was pre-diabetic at the time. On an exam, she had a BMI of 40. She was an obese African-American female, blood pressure 140/70 coming in, and labor just getting around the room. She had some signs of vascular congestion with a JVP that was elevated, but a relatively benign cardiac exam, also very common in this presentation. Some minimal non-pitting edema of her lower extremities. Here's a snapshot of her diagnostics. In the blood test, you can see that she has some degree of mild CKD, which becomes relevant, as Martha said, to this entire kind of entity of CKM, cardio-kidney metabolic syndrome, if you will. Otherwise, an A1C, putting her in prediabetes range, but importantly, an NT-proBNP of 52, which on our nomogram, as I'm sure for many of you, would be normal. Her EKG, normal sinus rhythm, and an echo showing an EF of 60 to 65% range, relatively normal chamber sizes. E to E prime also just in the 9 range, and this was read as normal diastolic filling pattern for age with normal RV function. And so the question here is, as you're seeing this patient in clinic or in any other arena, is this HFpEF? Do you have enough to call this HFpEF at this time, and would you just empirically begin treatment, or is more diagnostic testing needed? And we should have made this a voter response system question, but I'm going to just go with a show of hands perhaps. Who in the room would say, this is HFpEF, I have enough, we should initiate treatments, and we'll obviously get to treatments in this talk. Okay, I think we have one maybe. And so perhaps the individual who raised his hand might empirically treat, who feels that more testing is likely needed. Okay, and the rest seem relatively undecided, and maybe we can convince you of one of these as we move along. So I'm going to pause here and just remind everyone about some definitions in the 2022 American Heart Association ACC HFSA guidelines. I'll bring your attention to the last row. HFpEF is defined as heart failure with an ejection fraction over 50%. There is new language in the guidelines that includes evidence of spontaneous or provocable increased LV filling pressures that might be in the form of elevated natriuretic peptides or non-invasive and invasive hemodynamic measurement. Now, there are a couple of scoring algorithms that have been validated and are now incorporated in the guidelines to help you determine your patient's risk of having HFpEF. The two that I'm going to highlight are the H2PEF score, which you'll see on the right, and the HFA-PEF score on the left. The H2PEF score really focuses on comorbidities and assigns a score for either low probability, intermediate, or high probability of HFpEF. The HFA-PEF score, on the other hand, focuses on functional and morphologic abnormalities. And each of them, again, provides sort of a score to allow you to assess, is more testing needed, or am I pretty certain this is HFpEF? Now, interestingly, our patient has a score of 2 by the HFA-PEF algorithm, putting her in the low, certainly low to maybe intermediate risk probability. And by the H2PEF score, she scores a 4. And again, putting her in that intermediate probability range. And this is actually, as it turns out, the vast majority of patients that we see in our program. So the scores are helpful when they're quite high or really very low, but many patients with cardiometabolic syndrome end up in this mid-range. Now, we have a high propensity of taking patients to the cardiac catheterization lab for what we consider gold standard diagnostic testing. We formerly used to do resting right heart catheterization assessment, but we and others have shown that that can often miss the diagnosis, and so we will try to do supine bike exercise testing when possible. And you can see here that at baseline, her hemodynamics are relatively quite normal. Her right atrial pressure is not too elevated, borderline. Her wedge pressure, importantly, the PAWP listed is 11, which would not meet criteria for HFpEF. But just with 35 watts of exercise, and for those who are not familiar, we're talking 6 minutes on a bicycle test, pretty low intensity exercise. You can see all of her filling pressures go up, her right-sided pressures, her pulmonary pressures, and importantly, her wedge pressure up to 30, qualifying as exercise-induced HFpEF based on a wedge pressure over 25 with exercise.
All right, so how do we treat HFpEF and, in the current era? Well, we do have guidelines, right? We have these guidelines, you already heard them mentioned, the ones that came out in 2022, which I'll go over, but I'll just say that, as all of us in this room know, there's been an emergence even since those guidelines. It feels like every day we have a new heart failure study that might change this level of recommendations for certain medications. And I guess we'll wait and see. I think the heart failure community is quite responsive to new therapies. So perhaps these are going to change. I'm not really sure. But right now, as of the 2022 guidelines, there's a class, this is for HFpEF specifically. We have a recommendation about controlling blood pressure. Well, we should control blood pressure on everyone, so I think that's a pretty common thing that we should be doing regardless of the presence or absence of disease, but certainly in HFpEF, this is an important part of the management. But you can see that all the other recommendations for HFpEF are not class 1 indications. They are class 2A if you were talking SGLT2 inhibitors or control of atrial fibrillation, and then everything else is really a class 2B as of 2022, and that was the MRAs, the ARBs, and the ARNIs. And we're gonna talk a little bit more about these medications. And we gave a class 3 no benefit recommendation for nitrates and PDE5 inhibitors. And prior to that, we didn't really know. As you all remember, when you had a patient with HFpEF, really what treatment did you have until recently? I mean, it was really like if they had excess volume, you would use a diuretic, but really we didn't have a treatment for HFpEF. And now we're gonna go through some of the trials together, but I do think this is like a changing landscape, because before, even if you made the diagnosis, a lot of people will be like, what do I do with this patient? And it is a very changing environment. One of the trials, though, that gave us some hope was the Paragon HF trial. It was not a significant trial. Everybody called it a negative trial. This was the trial that looked at our ARNI medication, and I'm sorry I always trip over this medication in public, but comparing it to valsartan, the ARNI medication that they used, they found, you can see these lines started splitting, but it was not statistically significant. Now there was a hint of heterogeneity in women, and where maybe women were more responsive to an ARNI compared to men, but again, and they actually had good female enrollment. It was almost 50% women in this trial. So I think that was a hint that there might be a role for this medication, and maybe for once a medication that we might be able to use in women. But that's where we are right now, and that's why at the time that the guidelines were written, why they were unable to give it a very high level, class 1 recommendation. Oh, and here's just again a little bit more of the data related to heart failure hospitalizations. You can see that's probably where the difference was, even though again it wasn't statistically significant in those who received ARNI compared to valsartan, but cardiovascular death, it did not change. So I'm going to pass this over to you, Kavita.
Yep. So again, as Martha said, you know, for decades really, we had no therapies with proven benefit. Treatment of HFpEF was really focused on treating the comorbidities, yet the outcomes in these patients were very similar to HFrEF, so both for hospitalization and for mortality. And so the concept of GDMT, frankly, in HFpEF has really only come about in the last 5 years, which is remarkable. We're going to segue to SGLT2 inhibitors. Of course, you all are familiar with these agents, and there's so much excitement across ejection fraction in heart failure treatment. We're starting with the Emperor Preserve trial, as you can see here, just shy of 6,000 patients with an EF greater than 40%, randomized to empagliflozin versus placebo. And this was not a near hit. This was a true out of the park win here, so to speak, with the curves splitting quite early in the trial. And this was followed by the Deliver trial, again, just about 6,000 patients, EF over 40% with dapagliflozin versus placebo, and very similar findings here of significant benefit for composite cardiovascular outcome. And you can see the number needed to treat of 32, which is essentially, you know, really to date had been unheard of in HFpEF, certainly. So we think that obesity underlies much of what we see in HFpEF, and there are a couple of different mechanistic paradigms that have been proposed, really primarily visceral adiposity, which is quite harmful, we feel, leading to inflammation, metabolic dysregulation, ectopic fat deposition, and mechanical effects, also causing not just cardiac maladaptive issues, but also skeletal muscle reserve compromise as well, and downstream leading to neurohormonal dysregulation. And this has been proposed in a number of recent papers. There's the amazing heart failure prevention paper from Martha and Anulala that is worth a read in JCF, and more recently, again this year, Milton Packer has described the adipokine hypothesis in JACC. It's really a tour de force of this idea of really maladaptive fat causing downstream cardiovascular disease. And on that note, we're going to segue to GLP-1 receptor agonist therapy. And so beginning with the STEP HFpEF trials. So these were 2 studies that were run in parallel. One was with semaglutide in HFpEF patients with diabetes, and the second being semaglutide in patients without diabetes. Both studies met the primary endpoint of improvement in KCCQ score, as well as change in body weight, as you can see here. And so we do have the early signs of benefit from this therapy from the 2 simultaneous STEP trials, and this was then followed by the SUMMIT trial. SUMMIT looked at tirzepatide in patients with EF greater than 50%. Again, all of the trials had a sequential dosing protocol that was in place. That is what we typically do in practice as well when we're prescribing these agents. But the SUMMIT trial had a primary cardiovascular combined outcome in addition to KCCQ score. It met the primary outcome. The CV benefit was driven by heart failure hospitalization, which is important to recognize, but again, really adding to the data supporting these therapies. Segue to Javed.
Okay, so you know, it's really interesting that even if you look at almost 7-8 years ago, we've been trying to find therapy for patients with heart failure and preserved ejection fraction for over 2 decades, with every single trial being negative. Now, some of the trials had some subgroups that were being positive. That's why you saw sort of the guidelines giving a class 2B recommendations to things like MRA and valsartan, sacubitril, and ARB therapy. SGLT2 inhibitor was really the first positive trials in patients with heart failure and preserved ejection fraction. And actually, the importance of SGLT2 inhibitor trials being positive were actually multiple fold. So one is that now you have a therapy that works across the spectrum of ejection fraction, so you can start the therapy while you're awaiting all the evaluation and stuff like that. But the biggest thing was the psychological impact, and that is that heart failure with preserved ejection fraction is not an invincible disease, right? I mean, you can come up with therapies that can improve the outcome for these patients. Now, you saw the guidelines in 2022 that gave a SGLT2 inhibitor a class 2A recommendation, but remember that's for a technical reason, because when the guidelines were being written, there was only 1 trial out, and in order to have a class 1 recommendation, you need to have at least two-trial evidence. By the time the second trial came out, the European guidelines and the other guidelines were updated, and it's squarely a class 1 recommended guideline in patients with heart failure. And then subsequently, the American College of Cardiology had an ECDP, an expert consensus decision pathway, that also recommended that in the absence of contraindication, patients should get it. So now we are on track to manage patients with HFpEF a little bit better as well, and not just control blood pressure or give diuretics. Lots of interest in obesity-based therapies, as Dr. Sharma mentioned, a couple of trials showing improvement in symptoms. Longer outcomes trials are going on right now to see what is the impact on morbidity, mortality. So here we are in heart failure with reduced ejection fraction with 4 foundational therapy, and yet we are concerned that on one hand, the risks used to be really high, and with this 4 foundational therapy, it has really come down, except that age and sex match control, their risk is still way lower, right? So we need to do more work. So are we done with SGLT2 inhibitors in HFpEF? Is one therapy alone? And the answer is unfortunately no. These patients are at comparable risk for mortality, for hospitalization, for adverse quality of life as compared to heart failure with reduced ejection fraction. And SGLT2 inhibitors are great in terms of improving the outcome, but simply not enough. And we need more therapies, which brings us to the role of MRA therapy in patients with heart failure with preserved ejection fraction. Now, aldosterone being related to cardiovascular disease, this is not new news. We've known that for a long time. But sort of the idea was, sodium fluid retention, hypertension, hypertensive related sort of issues. But obviously that thought process has really evolved, and it has evolved that it is beyond just the hemodynamic or sodium electrolyte fluid balance, but it has actually aldosterone dysregulation has direct effect on and organ damage itself, whether it is related to remodeling, both myocardial remodeling, electrical remodeling, risk for arrhythmias, fibrosis, all of these things that lead to both development and progression of heart failure. Now, the good news is that when you have these pathophysiologies that lead to both development and progression of the disease, then if you give effective therapy, the same therapies may help you with both prevention and treatment as well. We are going to focus on HFpEF, but we have data with things like finerenone in patients with diabetic kidney disease for prevention of heart failure as well. Maybe we'll keep that for the Q&A session. So these patients are at a higher risk for heart failure, hospitalization, high risk for mortality, poor quality of life. And the question is, would MRA therapy improve outcomes for patients with HFpEF beyond the improvement in outcome with SGLT2 inhibitors? Well, this is the first time when this issue came up. There was a large trial done called the TOPCAT trial with spironolactone, a steroidal MRA in patients with heart failure and preserved ejection fraction. That trial, I would say, sort of one of the most controversial trials in my career because we are still sort of going back and forth and talking about it. The bottom line is, as you can see, the trial was neutral, was negative, did not improve outcomes for patients with heart failure and preserved ejection fraction. So that sort of really led to this whole issue of why. So either we got the pathophysiology wrong and that aldosterone is important in maybe post-MI patients or HFrEF patients, but aldosterone is not important in heart failure with preserved ejection fraction. That is sort of one hypothesis. The second hypothesis is that maybe there was something wrong with the trial. And the third hypothesis is that maybe we need a different mineralocorticoid receptor antagonist and maybe steroidal MRAs are not as good. So these are sort of the questions that come up when a trial results are neutral. Well, the answer to the first question that aldosterone is not important in pathophysiology, that would not borne out from any animal studies or mechanistic studies. Aldosterone clearly is important in terms of the pathophysiology. In terms of the clinical trial issue, of course, there was a lot of irregularities in this clinical trial. There were huge regional variations that in some regions of the world the patients tended to benefit, in other regions of the world patients did not benefit. So usually, most clinical trialists would write off these results. You always sort of, do multiple subgroup analyses. You see these regional variations. Maybe you shouldn't make a big deal out of it. Except that here it was a little bit different. The reason why it was different is that the regions that did not show benefit, if you look at the blood test for the metabolite of spironolactone called kenrenone, the metabolite levels were low or absent. The patients were not developing hyperkalemia. So the question was, and then as you look at it, that the absolute risk was low. So the questions came up whether these patients really had heart failure with preserved ejection fraction, were they even taking medication? So we needed to answer the question. But the bottom line is that the clinical trial was not positive. So then over time, obviously, science continues to progress and we get better molecules, and then came the non-steroidal MRAs, finerenone, and was tested in patients with heart failure and preserved ejection fraction. Now, the first question is there a difference between steroidal and non-steroidal MRAs? And that's a really difficult question because as clinicians, all three of us and all of you in the audience, we would really like for all the drugs within a class to be classified as the very same drugs because it makes life easy. Whatever you have available, you go ahead and give it to the patient. The problem is that we have tried this many times over. There are molecular differences between these drugs, and when you try them out, you find out that there are differences. So I'll give you two quick examples. When you look at beta blockers, carvedilol, long-acting metoprolol, and bisoprolol improve outcome in heart failure, but bucindolol and nebivolol did not. Those trials were not positive. If you talk about prevention of heart failure or prevention of complication in diabetes space, we know that DPP-4 inhibitor saxagliptin was actually associated with increased heart failure events. If you look at alogliptin, it also was not statistically significant but went in the wrong direction. But if you look at other DPP-4 inhibitors like linagliptin or sitagliptin, they were completely neutral. There was no higher risk. So there are always these differences. So the question for us as clinicians is, what do you do when you don't have head-to-head data, right? You don't have head-to-head data with steroidal, non-steroidal, although there is some head-to-head phase 2 data where the risk of hyperkalemia was lower with finerenone as compared to spironolactone, but not outcomes data. So then what do you have left? Well, what you have left is pharmacokinetic differences, pharmacodynamic differences, and observational or subgroup analyses differences, clinical, to see whether there are differences between these two drugs. And for all three of these things, pharmacokinetic, pharmacodynamic, and clinical observational differences, there are plenty between steroidal and non-steroidal MRAs. So for instance, as you can see here on this slide, steroidal MRAs have a very long half-life. It gets converted into an active metabolite, very long half-life. With finerenone, the half-life is much smaller. The steroidal MRAs obviously have progestational side effects like gynecomastia or menstrual abnormalities, whereas with the non-steroidal MRAs, you don't have those sort of side effects overall. But in terms of the efficacy, the non-steroidal MRA has not only differences in the half-life, but the potency is very different, and the selectivity for the mineralocorticoid receptor is very different. So again, at least theoretically, there is more balanced distribution between the heart and the kidney as opposed to steroidal MRA, which is much more renal focused. So theoretically, one can now at least posit two differences. One is that with a balanced distribution to the heart and the kidneys, there may be more cardiovascular effect, whereas with spironolactone, with much more renal effect, there may be more hyperkalemia risk. And again, as I mentioned in ARTS, a trial where head-to-head comparison was done between spironolactone and finerenone, the risk of hyperkalemia was higher with spironolactone. So now you have pharmacokinetic differences. What about pharmacodynamic differences? So again, if you look at translational research, if you look at basic and animal research, once you bind the MR receptor, depending on your binding site on the MR receptor, the further downstream activation, the gene activation profile is actually different for steroidal and non-steroidal MRA. And with finerenone, with the non-steroidal MRA, you get specifically activation of gene expression that would lead to anti-fibrosis, anti-inflammatory properties that are all obviously beneficial for the patient. So then the last question is where, okay, fine, there's no head-to-head study. are there any clinical evidence, observational studies that will show the differences? And the answer is plenty. So for instance, if you look at spironolactone, say in the TOPCAT trial, as the GFR goes down, the risk of hyperkalemia goes up, we know that. However, the benefit tends to go down with lower GFR. And now there are studies in patients with advanced kidney disease also that there is no benefit. Whereas we know with finerenone, there are specific CKD studies done, Fidelio, Figaro, where the benefit was seen irrespective of the GFR. So that's one difference between the two. Also, in terms of the CKM that Dr. Gulati mentioned, if you look at the data for new onset diabetes, with finerenone, the risk goes down. With spironolactone, we did not see that signal. What about other complications? For instance, atrial fibrillation. The risk of atrial fibrillation goes down with finerenone. We did not see that signal with spironolactone. So there are all of these differences that the best thing that I can say is that if at all possible, go with the therapy for which we have definitive evidence without necessarily extrapolating for where the evidence might not be. So what is the evidence of finerenone in patients with heart failure with preserved ejection fraction? That was tested in this trial called the Fine Arts study. These patients basically heart failure with preserved ejection fraction, EF greater than 40%. Patients, whether you were in the hospital setting, in the outpatient setting, were included. Patients with recovered ejection fraction were included. And then the dosing was stratified based on your baseline renal function. So if your renal function was preserved, eGFR greater than 60, then you start with 20 milligrams and then up titrate to 40 milligrams as tolerated. And if the GFR was less than 60, then you start at 10 milligrams and then you go to 20 milligrams. The primary endpoint was cardiovascular death and total heart failure events, first and recurrent, and then there were other outcomes looked at as well. So here are the results. So now we not have one but two agents that are positive in heart failure with preserved ejection fraction. Remember, this is a large outcomes trial. As you can see, the curves started separating early, continued to separate. There is a 16% relative risk reduction, a highly statistically significant result in favor of finerenone for reducing cardiovascular death and total heart failure events. If you look at total worsening heart failure events by themselves, there was an 18% relative risk reduction. Again, a highly statistically significant result. If you look at cardiovascular death and all-cause death, there was a directional difference of about 7% reduction, was not statistically significant. But remember, it is easier to show mortality difference in heart failure with reduced ejection fraction with effective therapies because about 80 to 85% of mortality is because of sudden cardiac death or progressive pump failure death. And those two causes of death share the common denominator, common pathophysiology. So if you have effective therapy, it's easier to show. Whereas in HFpEF, a good 40% of the mortality is non-cardiovascular, and cardiovascular mortality is also of more diffuse etiology, including, aneurysms and valve disease and whatnot. So in order to show, we unfortunately don't do studies in HFpEF to be able to detect a mortality difference, right? If you look at the all-cause mortality curve, I am willing to bet, and there's no way you can challenge me because there's no way to prove it, that if you were to do follow-up of these patients for another 2-3 years, that the curves will continue to separate and you will have a statistically significant difference, but you have a combined endpoint, so you go ahead and you stop the trial at an average follow-up of whatever 2 years or something like that. So it's directionally going in the right direction, but not statistically significant. However, the investigators did combine the CKD and the heart failure populations together to look at mortality, and at that time, the mortality benefit was statistically significant. In terms of explaining it to the patient, sometimes the relative risk reduction sort of an equation is difficult to explain. So these are actuarial analysis that what is the event-free survival for these patients. So that is about 3.1 year of excess event-free survival time with the use of this therapy. Now, one question that comes up is that, all these trials are going on. One trial is ending, the other trial is coming. So what is sort of the baseline care? And obviously when this trial started, SGLT2 inhibitors were not standard of care in HFpEF. When the trial ended, SGLT2 inhibitors are standard of care. So does it make a difference whether somebody is on an SGLT2 inhibitor or not? And the answer is absolutely no. And we have seen this over and over again, that if you give two drugs that have largely overlapping mechanism of action, then maybe all you're going to get is side effect but not much benefit. So for instance, if you give an ACE inhibitor and ARB together, you don't get any incremental benefit. But when you give therapies that are largely non-overlapping, background therapy doesn't matter, you get individual benefit from all of these therapies and they tend to be additive. So SGLT2 inhibitor versus not having been on SGLT2 inhibitor at baseline made no difference. Interaction p-value was completely negative. What about the side effect profile overall? So well, of course, it's still an MRA, while we think that because of the balanced distribution, the shorter half-life, the risks are lower than steroidal MRA. At the end of the day, it is still MRA and there is risk for hyperkalemia. But a few things to note. The risk of hyperkalemia gets balanced out by the lower risk of hypokalemia. And remember, the risk of arrhythmia is both at hyper and hypokalemia. So you do have a little bit of a higher risk of hyperkalemia and lower risk of hypokalemia. The second thing is, what about the clinically more significant hyperkalemia? In other words, hyperkalemia leading to hospitalization or leading to death. And the answer is no deaths related to hyperkalemia, and leading to hospitalization was equally balanced between the two arms. So this hyperkalemia does require obviously management and follow-up of the patients, follow-up of the labs, all the things that we as good clinicians would want to do. And some of these patients you may want to use lower dose, some of the patients may require a potassium binder, and some of those patients may require, if you're say between 5 and 5.5, careful watching. However, using the MRA, if you have borderline potassium, is still beneficial as opposed to not using. If you look at the absolute increase in potassium levels, they are very low. So it's not like on average everybody is becoming hyperkalemia, but few people, either multi-morbidity, age, maybe other medication interaction, whatever, few people are at risk, and that we need to manage. But on average, the increase overall is relatively very modest.
So just to go back about the thought of how we can prevent heart failure, you know, this is from our paper that I did with Dr. Anu Lala, and that was mentioned before, but we tried to think at right now, here in 2025, with all these new therapies and the new studies that were discussed, you know, where does everything fit in, and what should we be thinking about at different stages where different people will meet these patients? Again, most of our heart failure team, unfortunately, is meeting patients sort of in the stage D, advanced heart failure, or what we call tertiary prevention, where they've already had a VAD or a heart transplant. And of course, at that point, the common thing, though, at all the stages, though, is each of these patients at any of these stages still need management of the preventive therapies, whether it is, again, to reduce hospitalization, to control the risk factors that are present in that individual, and particularly the CKM sort of milieu that is associated with heart failure. So, you know, if somebody is meeting a patient in the sort of primary prevention phase, which would probably not be a heart failure physician, it would be more someone like me, or of course our primary care teams, depending, maybe they'll see more patients at stage A, but being able to identify an individual at risk, you may be able to already say, is this person at risk for heart failure, using the heart failure prevention scores that you heard about. We're not saying that they have to do the right heart cath, but if they identify a patient at risk, maybe that would prompt them to refer them to cardiology and say, is there more that needs to be done? Thinking, though, of patients with diabetes and chronic kidney disease, because of course our primary care physicians see a lot of those patients in their clinics on a regular basis, and identifying them once they see that, is this person someone that would be eligible for the non-steroidal MRAs? and thinking about these medications. Again, I know they haven't entered our guidelines yet, but very soon they should, just based on the evidence that we're seeing. Thinking, of course, about obesity and weight loss and using GLP-1 medications, that would be actually at every stage of heart failure, even the advanced stages. We're all talking about those patients too, actually, at least in my clinics, is we get sent them from heart failure and say, you know, is this someone that could be on these medications? Can we help get them on them? Thinking about other things that are part of the preventive therapies, things like cardiac rehab, things about screening, using biomarkers earlier, because that was introduced in the 2022 guidelines, yet I don't see it as something that's being applied on a regular basis. So I think all of this, just thinking about the right therapy at the right time, and again, depending on if you're a heart failure physician versus a general cardiologist versus a preventive cardiologist versus also our other colleagues that I started with saying that all of us are in this together and treating our patients, you know, is everyone's job. So joining in, identifying people at risk is the key at all these stages. So we didn't put colors actually for these different therapies because of a couple things. One, our current guidelines to put sort of a red, yellow, green type of thing at this point didn't make sense because it wouldn't be following our guidelines, but there's a lot of new therapies that we feel should be introduced and hopefully get class 1 recommendations, particularly for our HFpEF patients, where we really, to date, are very limited in how to treat them. And as a result of the guidelines being a little bit delayed with the evidence, even though the European guidelines have quickly caught on, the problem is always getting approval for these medications that could be effective and yet aren't always accessible.
Okay, so let's bring it back to our patient we were discussing earlier. Again, just as a reminder, we had kind of had a clinical presentation, some diagnostic tests suggestive of HFpEF, and then hemodynamic testing that was confirmatory. So 10 years ago, and I would actually say even 5 years ago, if she had presented in 2020, we would be focusing on blood pressure management. We would probably initiate MRA therapy. She'd be on a background diuretic following those cath numbers, and we would focus on lifestyle interventions, which not to say that these are now less important. They are still all part of the treatment algorithm, but we really didn't have much in the way of proven therapies. Today, we would at a minimum continue MRA therapy, but based on now the growing data from fine arts and the sub-studies of non-steroidal MRA therapy, consider even a switch to non-steroidal MRA therapy. Certainly, if a patient were to come in de novo with a HFpEF diagnosis, the goal would be to try to get them on non-steroidal therapy up front if possible. Maintain background diuretic therapy, adding SGLT2 inhibitor therapy, and that is irrespective of diabetes status. And if this patient were to remain hypertensive, to consider a switch to ARNI therapy. And often that will help with that polypharmacy that we see so many of these patients struggle with without really having a guideline indication to be on, for example, beta blockers, calcium channel blockers. So not to minimize the hypertension guidelines, but now we are moving into a slightly different disease state, and we have therapies that may have an added benefit to the heart failure syndrome, not just the hypertension management. Adding GLP-1 receptor agonist therapy for her obesity, and then considering device therapies, and of course enrolling in clinical trials, which I will always put a plug in for, as we don't learn and we don't get to understand these new therapies without our patients participating in trials. So hopefully this was helpful for you all to see the journey of where we have come in the last 5 years, particularly with Javed's exceptional discussion of non-steroidal MRA therapy and where we are today.
Excellent. So we will now start taking questions. So please feel free. There are many questions here. So I'm hoping that Dr. Sharma and Dr. Gulati have their running shoes on, and we can have a whole bunch of questions answered in the last about 8-9 minutes that we have. So I'll actually take the first question that says that are there any trials comparing steroidal and non-steroidal MRAs? And the answer is yes. As I mentioned, there was the ARCH-HF trial done. So that was actually a dose-ranging safety sort of a trial and not necessarily an outcomes trial. And in that trial, there was clearly a higher risk of hyperkalemia with steroidal MRA spironolactone as opposed to non-steroidal MRA. But there are no head-to-head large outcomes trials overall. So Dr. Gulati, question for you. When you treat patients with HFpEF, what are you targeting? Are you targeting sort of giving the patients GDMT or only improving their symptoms or trying to lower their NT-proBNP? What are you trying to target?
I think for my patients, I'm usually targeting their symptoms. I think, so I take care of a lot of patients who have ANOCA, so non-obstructive coronary artery disease, and there's a very close link with HFpEF and ANOCA, and probably at least a quarter of our patients who have ANOCA also have heart failure with preserved ejection fraction. And for both of these diseases, you know, like the biggest thing that brings in these patients is their symptoms. So we are targeting their symptoms and their quality of life. And that really matters to the individual in front of us, and also trying to make them more functionally active. I think that is the biggest thing, because like for the patient we heard from, you know, her life was getting quite limited, it sounded as though, and that's usually a very common scenario in my clinic. So I'm really always targeting symptoms. I don't know if you guys have a different way of deciding that you've got them on optimal therapy, given that we still have some limitations in accessing medications for this population.
You know, absolutely. I mean, you know, the patient symptoms are the reason why the patients come to us. So one is obviously the GDMT, optimal diuresis, control of blood pressure, control of atrial fibrillation, sort of all of those things that we can make our patients feel as better as we can. So Dr. Sharma, question for you. Very elegant case, but if you're in a community practice and somebody is uncertain of the diagnosis, other than sending it to the patient to you, can they do something in their own outpatient clinics and stuff like that to get to the next level?
Yeah, that's a great question. You know, obviously we don't all have access to quaternary care, highly specialized hemodynamic testing capabilities. There are surrogate testing modalities that can be used. One is exercise echo, so diastolic stress testing is a modality that can be used. There are some limitations, particularly related to body habitus, so your most obese patients, quality of image and really that fidelity you will get from the read might be a little bit challenging there, but it's really a confluence of all the tests coming together and your clinical suspicion first and foremost. And so some things that we didn't mention in this case, if she had been hospitalized for heart failure and had been administered diuretic therapy in a ER or hospital setting, that itself increases the pretest probability of the diagnosis significantly when they land in your clinic. And so there are aspects of the history that can help there. There is an effort to move towards BMI adjusted, so to speak, NT-proBNP. So you can also take that NT-proBNP with a little bit of grain of salt there, that, you know, normal by the standard EPIC or whatever your EMR system is, nomogram, does not necessarily mean normal in your very obese patient. And so looking at trends of NT-proBNP can help, but really at the end of the day, it's a clinical diagnosis.
Great. Maybe I can take quickly the next question, and that is, does finerenone cause much diuresis? So remember that all mineralocorticoid receptor antagonists has the potential to cause natriuresis and diuresis, but it's usually at a much higher dose than we do for clinical purposes. So when we are giving it to patients with heart failure, we are giving it for aldosterone modulation, not for the natriuretic properties. So if you think about your patients with, you know, cirrhosis or nephrotic syndrome or whatever, then you're giving like 200 milligrams or 100 milligrams or something like that. The problem here is that with heart failure patients, the risk of hyperkalemia is such that in the long run, we don't give those sort of doses, so we give much smaller doses. So the answer is, could it? Yes. At the doses that we give, no. If your main focus is to diurese the patient, then obviously things like loop diuretics and SGLT2 inhibitors and ARNI would have more effect on diuresis overall. Dr. Gulati, a quick question for you. So shortness of breath and fatigue, okay, fine. We think about heart failure. Are there any sort of atypical ways that heart failure patients may present to you?
Well, I hate the word atypical, as some people know,
Yes,
from
yes.
from even our chest pain guidelines. I think the problem is often this issue related to HFpEF specifically that disproportionately affects women, and that is the problem really of really understanding that women's symptoms may be different from men. Whether we're talking ischemic heart disease, whether we're talking about HFpEF, but I think that listening to our patients is really important. I really loved how your patient, Javed, described, her fatigue and not being just, tired, and what the difference between those two things are. And I think that when you ask about what people are doing or able to do, their activities of daily living, you do learn a lot about the symptoms and the way that they have started to slow down, and the lack of activity that many of these patients have. Shortness of breath tends to be a very common symptom, but I think the difference for women specifically is they describe things differently. They'll describe what they're feeling with more words and more symptoms usually than men. So there will be the shortness of breath, there will be the fatigue, there will be sometimes chest pain, which is not ischemic, or it might be ischemic, because again, as I told you, INOCA is very strongly associated with this. They can have, just simply present with leg swelling, and that may be the only symptom that they have. And most people will diagnose them with, you've got varicose veins, this is just due to genetics, and they don't get the diagnosis.
So there was a reason why I was smiling when I asked you the question, like who decides typical, right?
Yes.
Exactly, and that's sort of our biases that gets built up. Kavita, quick question for you. When would you not use finerenone? Any contraindications or any cautious concerns?
Well, I think maybe this is something that would love your input here, Javed, but patients who've had really significant hyperkalemia in their history, certainly if they've been hospitalized previously with truly clinically significant hyperkalemia. I think what often happens is the threshold of hyperkalemia, I think for those of us certainly in advanced heart failure versus the threshold for stopping MRA therapy in a primary care office, it might be a little bit different, but it's really at your comfort level. But if it has been clinically significant hyperkalemia in that situation, I would pause at least.
I mean, absolutely correct. So, pregnancy, lactation, hyperkalemia history, current hyperkalemia, low GFR, all of those things that you would be concerned. So in 30 seconds, I have a really simple question for you, Kavita. So you got diagnosed with HFpEF, you have the GDMT, what other diseases you need to rule out?
Yeah, that's a great one, but 30 seconds is not very fair to answer that. But there are, mimickers, as we say. I think it's important, depending on the presentation, to consider other diagnoses that could be coming in masquerading as HFpEF. One of the important ones, of course, is cardiac amyloidosis. We have published on this and others as well. For me, a patient coming in without the typical comorbidities and risk factors for HFpEF, so for example, lean body physique, no hypertension history, not having diabetes and CKM syndrome, but elevated NT-proBNP or high sensitivity troponin, with or without LVH, with or without the classic echo markers, really raises my suspicion and I think warrants further testing. And then we also have to think about that spectrum of hypertrophic cardiomyopathy that may not be HOCM, because that tends to be clinically more obvious, but that LVH that is disproportionate to the history of hypertension. We might be looking at an HCM presentation and perhaps genetic testing and further MRI and specialized testing is needed. There are, of course, all the zebras out there, sarcoidosis and whatnot, but you usually have other extra cardiac or cardiac clues such as arrhythmias, which are not typical of HFpEF.
Well, great. Thank you very much. I always learn a lot when I work with you all, and thank you everybody, both on our virtual group and the group that is here in the room. Thank you so much for attending. You can scan this QR code to earn your credit as well. We will hang around here if there are some live discussions and questions. And to earn your CME credit, you can click there and you can also evaluate. Thank you so much for attending this session.